I think as far as the anatomy of the retina is concerned, I had sent a recorded PPT. I think you must have all gone through it, because knowing the basics of nomenclature that is used for naming various parts in the retina is very much important in studying this particular topic, which is very important clinically. Diabetic retinopathy is extremely important because it's very common in occurrence, and you find a lot of people asking your suggestion for the treatment of diabetic retinopathy, and you can find a lot of questions both in the form of main question, and various parts of this diabetic retinopathy can be asked as short notes, and a lot of viva voce questions can appear in diabetic retinopathy. So today we will study something about diabetic retinopathy. Diabetic retinopathy is a disorder of the retinal vessels that eventually develops to some degree in almost all the patients with long-standing diabetes mellitus. It contributes to 4.8% of the 37 million cases of blindness throughout the world. Most common cause of bilateral blindness in Western countries is because of the diabetic retinopathy. A recent study in urban population in South India estimates the prevalence of diabetes mellitus in adults population as high as 28%, and the prevalence of diabetic retinopathy in diabetics to an extent of 18%. That makes it an important point to study in detail about the diabetic retinopathy, clinical features, and various modalities for treatment of diabetic retinopathy. The risk factors, 50% of them who are diabetic, they develop 50% of them, the persons who are having diabetic retinopathy for a period of 10 years can develop diabetic retinopathy, and in people who are having diabetes mellitus for about 20 years, around 70% of them are likely to develop diabetic retinopathy, while most of the people, that is around 90% of the people who are having diabetes for about 30 years, are likely to develop definitely some sort of or some stage of diabetic retinopathy. Female to male ratio is around 4:3. Heredity is more often observed in case of proliferative diabetic retinopathy. The full form of PDR is proliferative diabetic retinopathy. Here I would like to mention a point which is off the textbook. There have been studies in various parts of India wherein they are trying to do the genetic pattern. They are trying to assess the genetic pattern of the people who develop diabetic retinopathy in some particular genetic pattern, which is not yet very well confirmed, and it's in the process of getting confirmed. In one particular genetic pattern, it is unlikely to develop diabetic retinopathy, and probably in future you can assure these people with this particular genetic pattern that you can assure the patients that you may not develop diabetic retinopathy in future. Anyway, it's still in the experimental stage. The risk factors. Apart from diabetes alone, there are some risk factors. Worsening of diabetic retinopathy and even the prognosis of diabetic retinopathy are influenced by comorbidities like systemic hypertension. Then if the patient is having poor diabetic control, in that case also there can be diabetic retinopathy changes, hyperlipidemia, smoking, associated diabetic nephropathy, anemia, pregnancy, obesity, and after cataract surgery also there will be acceleration of the process of diabetic retinopathy, and hence whenever you see a case of cataract along with diabetic retinopathy, we normally treat diabetic retinopathy first before treating cataract surgery, because post cataract surgery the patient is likely to get his diabetic retinopathy changes accelerated, and due to this observation we normally treat diabetic retinopathy first when cataract and diabetic retinopathy are coexisting. Coming to systemic hypertension normally should be controlled with at least 2 drugs, especially when it's associated with type 2 diabetes mellitus. And in such cases, they have observed in various studies that the diabetic retinopathy changes have come down dramatically, very well, has come down very well dramatically after treating systemic hypertension really well. Before understanding the clinical features of diabetic retinopathy and the classification of retinopathy, we must try to understand the various pathogenetic stages of diabetic retinopathy. This is a summary from the Parsons textbook. The first thing that happens will be breakage in the blood retina barrier. There will be breakage in the blood retina barrier, which is a strong barrier, and there will be loss of intramural pericytes in the vessels, which will cause formation of microaneurysms. There will be thickening of the basement membrane, and there will be progressive closure of the capillaries due to occlusion of the lumen. Aggregation of platelets is an abnormality that is observed in diabetics, which causes capillary non-perfusion. All these 5 things result in what is known as hypoxia, decreased in oxygen level, and hence ischemia. After the ischemia develops, there will be development of VEGF, vascular endothelial growth factor. The full form of VEGF is vascular endothelial growth factor, which will cause IRMA, that is intraretinal microvascular abnormalities. After this, there is a stage of NVE and NVD. NVE is neovascularization. Due to hypoxia, there will be VEGF formation, which in turn causes neovascularization. New vessels are formed so as to combat hypoxia, and these new vessels that are formed are very fragile, and hence they break up and cause bleeding. NVE is neovascularization elsewhere, while NVD means neovascularization around the disc. As I told you, these vessels which are newly formed are extremely fragile and friable, and they break up so as to cause bleeding. Later, there will be fibroblastic reaction and proliferation, which will cause tractional bands, and these tractional bands apply the pressure over the surface of the retina, and they pull the retina from its attachment to the underlying structures, and hence there will be formation of a retinal detachment. If you understand the pathogenesis of diabetic retinopathy in these 10 steps, it's very easy to understand the whole of diabetic retinopathy along with its treatment. This is a flow chart of the same thing which I've explained. So you can use this flow chart so as to figuratively describe the pathogenesis of diabetic retinopathy. Hyperglycemia giving rise to retinal blood flow, breaking the growth factors, and finally it ends up in neovascularization. Neovascularization causes, as the vessels are very fragile, it causes hemorrhage. This is diagrammatic representation of the pathogenesis of what happens in diabetic retinopathy. So you must remember that loss of pericytes is the first pathological change that occurs. Next you have formation of vascular endothelial growth factor. This is one of the angiogenic stimulator which will cause new vessel formation. Two more not so important are platelet derived growth factor, hepatocyte growth factor. These are also angiogenic stimulators. Whenever you know something about angiogenic stimulators, you should also learn about angiogenesis inhibitors. Endostatin, angiostatin, and pigment epithelium derived factor are the things that being used as known as angiogenesis inhibitors. So what happens due to these pathological changes which you have observed? Some 10 pathological changes which you have observed will give rise to all these things. That is microaneurysm formation at the vessel wall. There will be weakening of the wall due to loss of pericytes, and hence there will be slight microscopic dilatation in the form of microaneurysm formation. Next stage will be these aneurysms are very fragile, they break open and they form dot and blot hemorrhages. Through these places, there will be a fusion of the fluid and hence there will be a retinal edema. Next stage, these pathological changes are capable of causing intraretinal microvascular abnormalities, again in the form of dot and blot hemorrhages. Next, you have a wider hemorrhages in the form of retinal hemorrhage, and next stage will be neovascularization. New vessel formation due to hypoxia. Hypoxia causes VEGF release and hence there will be new vessel formation. So many a times you will be asked in the Viva OC, or you are supposed to know what is the earliest change in case of diabetic retinopathy. You will definitely be appreciated if you say the earliest change in diabetic retinopathy is microaneurysm formation. But if you want to be little better in answering that particular question, you can answer like this. Earliest sign in diabetic retinopathy, pathologically it is loss of pericytes and thickening of the basement membrane. Fluorescent angiographically there is leakage of fluorescent dye, and ophthalmoscopically microaneurysm formation. That makes it a better answer. And of course, you will definitely be appreciated if you say microaneurysm formation is the earliest change that occurs in diabetic retinopathy. So this is the picture of microscopic picture of microaneurysm formation. There will be loss of pericytes. There will be dilatation of the vessels. There will be weakening of the endothelium, and hence there will be bulging of the vessel. And you can see sometimes the thrombosis of this microaneurysm also, which later causes dot and blot hemorrhages. So how the dot and blot hemorrhages are formed? When the wall of a capillary or microaneurysm is sufficiently weakened, it may rupture, giving rise to an intraretinal hemorrhage. And if the hemorrhage is deep, that is in the inner nuclear layer or outer plexiform layer, it usually assumes the shape of a round or oval, and hence the name dot or blot hemorrhage. This is diagrammatic representation of what happens later, that is retinal edema formation. Consequences of chronic leakage leads to retinal edema, and finally it can also lead to hard exudates. You must know the level at which the hard exudates are present. In the red arrow, I have shown the level, that is inner nuclear layer, and outer plexiform layer is a layer in which the exudates are found. They are round and regular hard exudates. If they are fan shaped exudates, then it is superficial exudate in the nerve fiber layer, and in the nerve fiber layer also sometimes you get flame shaped hemorrhages. Even though flame shaped hemorrhages are characteristic of hypertensive retinopathy, when diabetic retinopathy is coexisting with hypertension or hypertensive retinopathy, then you can see both dot and blot hemorrhages, deep hemorrhages, and also superficial hemorrhages in the form of flame shaped hemorrhages. Consequences of retinal edema, as I told you, whenever there is retinal edema, there will be hypoxia. Once there is hypoxia, there will be vasoproliferative substances that are formed. Once the vasoproliferative substances are released, there will be new vessel formation both in the form of NVE. NVE is neovascularization elsewhere. NVD, neovascularization in the disc. When it becomes much more severe, it can also cause neovascularization in the trabecular meshwork. It can also cause neovascularization in the iris also. When there is neovascularization in the iris, it is referred to as rubeosis iridis, and it is capable of causing neovascular glaucoma, which has got a very bad prognosis. So hence, whenever you are treating a case of diabetic retinopathy, prevention of the diabetic retinopathy changes is very much important. And hence you should know the earliest changes of diabetic retinopathy and try to treat the diabetic retinopathy in its early stages to avoid various dreaded complications. So coming to the summary of pathogenesis, if you observe very carefully, you can observe that there is both leakage and blockage. Anyway, those terminologies should not be used because they are not supposed to be used by the medical student. So you are supposed to remember basically that is increased permeability and obstruction in the lumen of vessels. Why there is increased permeability? The causes will be loss of pericytes and some kind of an abnormal material gets coated on the endothelial wall, and hence there will be endothelial cell damage in case of diabetic retinopathy. These are the causes for increased permeability and various things that happen in diabetic retinopathy. Next, you have obstruction due to abnormal fibrinolytic system, which is observed in case of diabetic patients. There will be hyperviscosity in the blood causing release of alpha and beta globulins, which leads to erythrocyte aggregation and platelet aggregation also. In fact, in cases of diabetic people, platelets release some kind of prostaglandins which help in which cause the abnormal aggregation of the platelets, and the basement thickening is one of the other causes for obstruction. So basically the pathogenesis consists of increased permeability and the obstruction in the lumen of the vessels, which are all the reasons as to why you see various clinical features which we are going to observe in diabetic retinopathy. The diagrammatic representation of the increased permeability, that is leakage, and occlusion of the lumen, that is blockage. This is a diagrammatic representation of the summary of the pathogenesis in a nutshell. Actually, no textbooks do give the symptoms of diabetic retinopathy, but anyway, I have tried to make a small attempt to describe the symptoms of diabetic retinopathy in case somebody asks you. It is normally asymptomatic. When you see various signs of diabetic retinopathy, which are present away from the macula, if the changes are present very close to the macula, only in such cases you observe that patient complains of dimness of vision or floaters and things like that. But if the clinical signs which you are observing as a clinician or an ophthalmologist are well away from the macula, usually the patient is asymptomatic, and sometimes when you suggest him some kind of treatment, he will definitely not agree. So it's your duty to convince the patient that diabetic retinopathy on a later date can bring down your vision, and hence treatment is mandatory. So then you can have what all symptoms are there due to retinal hemorrhage. Again, if it's very close to the macula, it can cause dimness of vision or some kind of black patches in the field of vision if the hemorrhage is wider and little away from the macula. Symptoms can be due to vitreous hemorrhage, sudden, painless. Total loss of vision can occur due to vitreous hemorrhage, and symptoms due to macular edema, dimness of vision, symptoms related to retinal detachment, and sometimes color vision also known to be affected in case of diabetic retinopathy. Signs and the classification of diabetic retinopathy go hand in hand. So when you want to know the signs of diabetic retinopathy, which you have almost studied in your pathogenesis of diabetic retinopathy itself, So you have to know various types of classification. The simplest classification is this, wherein you have background diabetic retinopathy with a few microaneurysms. Then you have diabetic maculopathy, wherein the changes are exclusively in the macula causing dimness of vision. Background diabetic retinopathy per se cannot cause dimness of vision, while diabetic maculopathy can cause gross loss of vision. Then you have pre-proliferative diabetic retinopathy and proliferative diabetic retinopathy. You must know the difference between pre-proliferative diabetic retinopathy and proliferative diabetic retinopathy, because it's a very frequently asked YOC question. The difference between pre-proliferative diabetic retinopathy is that no neovascularization in pre-proliferative diabetic retinopathy. In proliferative diabetic retinopathy, you use the nomenclature proliferative diabetic retinopathy only when the new vessels start appearing. That is the demarcation between the pre-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Advanced diabetic disease is associated with vision-threatening complications like vitreous hemorrhage, neovascular glaucoma, tractional detachment, etc., which we are going to study in the next few slides. Next popular classification is early treatment diabetic retinopathy study classification, ETDRS, early treatment diabetic retinopathy study group. Gives a classification wherein it classifies diabetic retinopathy into 7 groups. The first one is mild non-proliferative diabetic retinopathy, wherein you have only microaneurysm or intraretinal hemorrhage. Moderate NPDR, the microaneurysms and the intraretinal hemorrhage in 2 or 3 quadrants when they are present, plus early mild IRMA. IRMA is intraretinal microvascular abnormalities, which are again dot and blot hemorrhages. Severe NPDR, any one of the 4 quadrants of severe aneurysms and intraretinal hemorrhages, 2 quadrants of venous bleeding and 1 quadrant of IRMA changes. This is referred to as severe non-proliferative diabetic retinopathy. Very severe non-proliferative diabetic retinopathy, any 2 of the above. Coming to the proliferative diabetic retinopathy, there will be appearance of neovascularization around the disc or neovascularization elsewhere. Once the neovascularization occurs, we call it as proliferative diabetic retinopathy. Diabetic maculopathy is a different entity altogether, wherein you see most of the changes around the macula or in the fovea, diabetic maculopathy. Advanced diabetic eye disease is due to the vitreous hemorrhage and organized vitreous hemorrhage, which can cause retinitis proliferans and then tractional retinal detachment. Tractional retinal detachment. This is a picture of mild NPDR along the superior temporal vessel. You can see some red dot, that is just a microaneurysm, and temporal to the macula you can see small red dots which are nothing but microaneurysms. This is normal fundus. You can make out that the normal fundus will be having a pinkish red background due to the choroid. You know very well that retina is transparent, and this color is purely due to the choroid that is underlying the retina, and it is described as pinkish red background without any red dots in between. You can clearly see the macula, you can beautifully see the vessels very clearly, and no abnormalities are there in this normal fundus. This is moderate NPDR with a few dot and blot hemorrhages and early exudates. Severe NPDR. All these changes are present in various quadrants. This is the case of severe non-proliferative diabetic retinopathy. I'm still calling it as non-proliferative because in this particular field there are no new vessels that are formed. There are no new vessels near the disc. There are no new vessels around in the periphery also, or new vessels elsewhere. NVE and NVD. NVD is new vascularization near the disc. This is very severe non-proliferative diabetic retinopathy. The whole of the retina is involved, but still there is no formation of new vessels, and hence the name NPDR, non-proliferative diabetic retinopathy. Coming to proliferative diabetic retinopathy, as I told you, the onset of proliferative diabetic retinopathy, the hallmark is presence of new vessels. So proliferative diabetic retinopathy develops in more than 50% cases after 25 years duration of diabetes. The hallmark of proliferative diabetic retinopathy is the occurrence of neovascularization over the changes of various very severe non-proliferative diabetic retinopathy. So the terminology NVD and NVE you should know very well. Neovascularization of the disc and neovascularization elsewhere. PDR can further be classified on the basis of high risk characteristics. This particular description or the classification is described by the diabetic retinopathy study group. So you have two groups, PDR without HRCs, that is early proliferative diabetic retinopathy, and PDR with HRCs. HRC is nothing but high risk characteristics. So PDR with HRCs is also referred to as advanced proliferative diabetic retinopathy. How do you assess high risk characteristics? This is how we are going to assess the high risk characteristic. Neovascularization of the disc, 1/4 to 1/3 of the disc with or without vitreous hemorrhage or pre-retinal hemorrhage. That doesn't have any risk at all. That has got a risk with or without vitreous hemorrhage or pre-retinal hemorrhage. NVD lesser than 1/4 disc area with vitreous hemorrhage or pre-retinal hemorrhage can also be of high characteristic. All these three are high characteristic. Or NVA of more than half disc diameter with vitreous hemorrhage or pre-retinal hemorrhage. So in all these three cases we call it as high risk characteristics proliferative diabetic retinopathy. Anything lesser than 1/4 disc diameter of neovascularization can be referred to as early proliferative diabetic retinopathy. So what happens in proliferative diabetic retinopathy? Proliferative diabetic retinopathy is very dangerous and vision threatening because it is the vascular fronts, as I told you, are extremely fragile and friable, and hence there will be repeated vitreous hemorrhages causing gross loss of vision, painless gross loss of vision. Later on, this vitreous hemorrhage can condense and become connective tissue, and retinitis proliferans can be there. There can appear, the epiretinal membranes can appear, and they start dragging the retina, and there will be posterior vitreous detachment and tractional retinal detachment, which all are very dangerous and highly vision threatening. So proliferative diabetic retinopathy is definitely more serious compared to non-proliferative diabetic retinopathy. This is early proliferative diabetic retinopathy with maculopathy. If you see near the disc on the temporal aspect, you can see a few strands of red strands, which are nothing but abnormal new vessels. So this is NVD. So here neovascularization of the disc is lesser than 1/4 the disc diameter, and hence it is not a high risk characteristic. If the neovascularization is more than 1/4 disc diameter, then only it is a high risk characteristic. So this is early proliferative diabetic retinopathy. You can see around the macula there are exudates, not exactly in the fovea, but they are temporal to the macula. So this is the case. Even though we study PDR and maculopathy separately and NPDR separately, all these things can coexist. Not that only in NPDR, only NPDR will be there, or in PDR, only PDR will be there. So there can be PDR with maculopathy. So coexistence of these morbidities can definitely be there. So NVD with HRC, I am calling it HRC because it is occupying a space which is more than 3/4 of the disc diameter. Almost 90% of the disc diameter is being occupied by the new vessels, which are fragile fronds, which you are seeing around the optic disc. This is a case of advanced stage of proliferative diabetic retinopathy, wherein the traction by the retinitis proliferans has caused fractional retinal detachment. How do you know that the retina is detached? Because it is not pinkish red. You can see the fibrosis, and the raised retina looks grayish like this. The arrows, you can refer to the arrows. The places where the arrows are pointing are looking grayish white in color. And this grayish white places are the ones wherein the retina is detached. Pinkish red places are the places where retina is still attached. So it is a case of tractional retinal detachment due to retinitis proliferans and fibrous tissue formation after the vitreous hemorrhage is organized. Now we will come to diabetic maculopathy. It's studied as a different entity. Changes in the macular region due to diabetic retinopathy can cause gross loss of vision. So it can be associated with non-proliferative diabetic retinopathy also, or it can be associated with proliferative diabetic retinopathy. The diabetic macular edema basically occurs due to the increased permeability of the vessels. Macula is normally in a avascular zone, but the vessels which are around the macula can start pouring the liquid, and hence there will be increased permeability and hence edema, retinal edema. The terminology clinically significant macular edema is very frequently used in diabetic retinopathy, and diabetic maculopathy is termed as clinically significant macular edema if one of the following three criteria are present on slit lamp examination with 90D lens. As you know through your previous knowledge of examining the retina, only with slit lamp you cannot examine the retina. You have to have 90D lens along with the slit lamp biomicroscopes to see the retina. So what are the criteria to say that it is CSME, that is clinically significant macular edema? There will be thickening of the retina at or within 500 microns of the fovea. Hard exudates are present at or within 500 microns of the center of the fovea associated with adjacent retinal thickening. Development of a zone of retinal thickening 1 to 2 disc diameter or larger in size, at least part of which is within 1 disc diameter of the fovea. This is a case of early diabetic maculopathy, supero-nasal to the macula. You can see a small exudate, but this is not capable of causing gross loss of vision. So in such patients, treatment is necessary, but the patient's vision is normal, and it takes more time for a clinician to convince the patient for treatment in such cases. Minimal macular edema is present, but it's present exactly in the foveal center. In this particular case, patient is also ready for treatment as there is vision that is affected. As a clinician, you are supposed to do parafoveal photocoagulation in such cases, which we are going to study in our later slides. Clinico-angiographically, diabetic maculopathy can be classified into 4 types. Focal exudative maculopathy, which is nothing but circinate maculopathy, wherein you have exudates all around the macula. Diffuse exudative maculopathy, wherein exudates are present not only in the macula, in the whole of the posterior pole. Ischemic maculopathy, it occurs due to microvascular blockage, and there will be gross visual loss. When you do fundus fluorescent angiography, there will be enlargement of foveal avascular zone. And you have the fourth type, the mixed maculopathy. Ischemic and exudative maculopathy, when they are coexisting, it is known as mixed maculopathy. Very easy to understand. This is a case of circinate maculopathy. If this picture is shown to you, you please observe that there is a circular collection or the collection of exudates, hard exudates in the form of a circle. These hard exudates are arranged in the form of a circle. This is referred to as circinate maculopathy. Whenever you see this picture, you have to say that this is circinate maculopathy. In rest of the fundus also you can see the exudates. So it is along with circinate retinopathy, you have exudates in the whole of the posterior pole also. Now we will come to the advanced diabetic eye disease. Whenever these diabetic changes are there, as I told you, new vessel formation will be there, and hence these fragile new vessels break and cause persistent vitreous hemorrhage, which forms a part of advanced diabetic eye disease, highly vision threatening. Tractional retinal detachment can be there once these vitreous hemorrhage are organized and then cause retinitis proliferans, and fibrovascular bands which pull the retina from its attachment. Then these new vessels can grow towards the trabecular meshwork and can grow towards the iris tissue, rubeosis iridis, and in such cases you can see neovascular glaucoma, which is also known as one of the entities in advanced diabetic eye disease. This is vitreous hemorrhage. As I told you earlier, pre-retinal subhyaloid hemorrhage is in the form of a boat, and hence whenever you are asked when do you see boat-shaped hemorrhages, or what is the name given to the boat-shaped hemorrhages, when do you see it? Subhyaloid hemorrhage or pre-retinal hemorrhage assumes the shape of a boat. This is classical pre-retinal or subhyaloid hemorrhage, which is assumed the shape of a boat. This is the picture of tractional retinal detachment. You can see that the superior part is totally detached and hence it looks grayish white in color, while the inferior part looks pinkish red and still it is attached. The retina is attached in the lower part. This is a case of neovascular glaucoma, wherein the red streaks which you are seeing are not the normal vessels, there are new vessels, abnormal, fragile new vessels, which are capable of causing NVG, that is neovascular glaucoma. So how are you going to manage the diabetic retinopathy? Systemic investigations, you know better than me, as far as systemic investigations are concerned. So I'll concentrate on ocular examination and ocular investigations. Systemic investigation, you have to check all these parameters which you know very well. Blood sugar, fasting, postprandial, complete hemogram, urea, creatinine, electrolytes, lipid profile, cardiovascular workup. All these things you know definitely better. You have studied all these things. And coming to the ocular examination, you have to check the visual acuity. Visual acuity can be normal in most of the cases, which are early stages of diabetic retinopathy. Intraocular pressure should be checked. Visual field should be examined. Anterior segment, look for neovascularization of the iris. Fundus should be examined, as I told you earlier, with the direct ophthalmoscopy, slit lamp biomicroscopy with 90D lens or contact lens. Indirect ophthalmoscopy should be done to find out whether there are any changes in the periphery. Fundus photograph should be taken for documentation of various changes before you give the treatment. This is the picture of direct ophthalmoscope. You must know the difference between direct and indirect ophthalmoscope, I keep telling you. So when do you call diabetic retinopathy patients for follow-up? Every year you have to call the patient for follow-up if he is having only mild NPDR. Every 6 months if the patient is having moderate NPDR. Every 3 months if the patient is having severe NPDR. And once the proliferative diabetic retinopathy ensues, you have to call the patient for follow-up every 2 months. This is the picture of indirect ophthalmoscope. You know very well that indirect ophthalmoscope has got a headset which is on your left hand side. On the right hand side you see 3 lenses. These are referred to as condensing lenses. Indirect ophthalmoscope should have both bright illumination and the condensing lenses to visualize the posterior segment. 13D lens, 20D lens and 30D lenses are usually used along with. Very frequently used lens is 20D lens. So if you are asked which is the one which is used in your hospital and your eye specialist uses, you normally mention 20D lens. We don't use 13 and 30D lenses. We don't use. We use most of the times 20D lenses. And you have to have a slit lamp biomicroscope and you have to use 3 mirror or 90D lens to visualize various diabetic retinopathy changes. Fundus fluorescent angiogram, fluorescent sodium dye is injected intravenously and the circulation of this particular dye in the fundus is examined by using this equipment, fundus fluorescent angiogram. This is the normal picture of the fundus fluorescent angiogram. There is no leakage anywhere. This is fundus photography. There is an equipment, fundus camera, which is used to document the diabetic retinopathy changes before and after treatment. Next equipment, very frequently asked, if you answer really well, then they'll ask you what is OCT. Optical coherence tomography is another equipment. It is especially useful in identifying the macular edema. You search the whole of the fundus, no changes are seen, but still the patient is complaining of gross loss of vision. If you use this equipment by name optical coherence tomography, you can beautifully identify the macular changes. It is more preferred nowadays because it's non-invasive retinal imaging technique for quantitative measurement of retinal thickness and characterization of retinal and vitreoretinal interface. It's a standard tool in the management of diabetic macular edema, as I told you earlier. Advantages of OCT over fundus fluorescent angiography, you must know a few points. It's a non-invasive and non-contact procedure. Instant direct imaging of tissue morphology, no preparation of the sample or subject, no ionizing radiation. But anyway, I would like to add one more thing. FFA has got more systemic risks than OCT. So OCT is more preferred in aged patients. Then you have one more equipment by name scanning laser ophthalmoscope, which is also used for assessing diabetic retinopathy cases. Then once you have diagnosed diabetic retinopathy and you have assessed various stages of diabetic retinopathy, you have to treat diabetic retinopathy. The basic thing before treating the diabetic retinopathy per se is to do a proper diabetic control and control of systemic hypertension, hyperlipidemia, make sure that the patient quits smoking. Diabetic nephropathy should be attended to, anemia should be treated, and obesity should be treated. Then other modes of treatment, you have protein kinase C inhibitors, anti-VEGF treatment, aldose reductase and angiotensin converting enzyme inhibitors, antioxidants in the form of vitamin E and intravitreal injections of triamcinolone. But the main line of treatment so far in diabetic retinopathy will be laser photocoagulation. Laser photocoagulation can be of various types. Focal photocoagulation, they concentrate on photocoagulating the area which is having new vessels. Only those areas are photocoagulated where you see more changes of NPDR. Parafoveal photocoagulation is advised for macular edema, wherein temporal to the macula, the area which is known as parafoveal. In this particular place, you do photocoagulation sectorial. The retina can be divided into 4 sectors. So that particular sector wherein you see more changes, only that particular sector can be photocoagulated. Pan-retinal photocoagulation, You have florid diabetic retinopathy, lot of changes are there in various quadrants. You cannot treat one quadrant or sector. Now you have to treat the whole of the retina. In such cases, we do what is known as pan-retinal photocoagulation in the periphery of the retina. The whole of the periphery of the retina, above the arterial arcades and below the arterial arcades, on either side of the arterial arcades, you are going to do what is known as pan-retinal photocoagulation in the far periphery of the retina. Treatment is indicated. Pan-retinal photocoagulation is indicated in PDR with HRCs, in neovascularization of the iris, in severe NPDR associated with poor compliance, wherein you are not sure that the patient is going to come for proper follow-up. Then just before cataract surgery, you better do, just before doing YAG capsulotomy, it's better you do green laser photocoagulation for the retina before you take up the case for cataract surgery and YAG capsulotomy. Renal failure and one-night patient are the cases wherein you better do photocoagulation earlier. And in pregnancy, it can be associated with other changes in the retina, and hence you better do, even though it's a case of NPDR, you better do pan-retinal photocoagulation. This is the picture of a patient being subjected to pan-retinal photocoagulation. You must know that the inside there is one lens, that is 3-mirror lens is necessary to direct the laser beams into various parts of the retina, and you can observe that there are 3 mirrors in the lens. The central part helps in photocoagulating the areas which are closer to the posterior pole. You must not photocoagulate posterior pole. You must coagulate areas which are closer to the posterior pole by the mirror which is present in the center, and 3 other mirrors will help you in tackling the areas of mid periphery and far periphery of the retina. You can observe that my assistant, she is wearing a protective goggle. So whenever you are getting your patient photocoagulated, make sure that you protect yourself with a goggle which is specifically for green laser photocoagulation. It will prevent your retina getting inadvertently photocoagulated. So you must be extremely careful. That protective goggle is not necessary when YAG laser capsulotomy is being done, but while green laser photocoagulation is done, it is necessary. There are 3 modes here. I am doing slit lamp delivery of green laser photocoagulation. Other modes of delivery of green laser is through indirect ophthalmoscope, and while you are doing posterior segment surgery, you can direct the laser by using what is known as endoprobe, which can be inserted through the pars plana region. This is just a diagrammatic representation to show you how I can direct the laser beam to various parts by using the mirrors that are present in the 3 mirror. Nowadays, we are using 532 nanometers green laser, and previously when I was a student, we were using argon blue. Some 25 years back, argon blue and argon green lasers were being used, but now by and large all of us use double frequency YAG laser, 532 nanometers green laser for photocoagulation of the retina. Other medicines that can be used for treating diabetic retinopathy, intravitreal triamcinolone, some people prefer as more superior to the grid photocoagulation, but I feel that photocoagulation in early stages is much better than simply subjecting the patient to advanced treatments. Fenofibrate is indicated for treatment of hyperglycemia and mixed dyslipidemia. Statins are also useful, and long-term lipid lowering therapy with fenofibrate reduce the frequency of laser treatment. Orally, you can also use calcium dobicelite, which is beneficial especially in case of non-diabetic and non-proliferative diabetic retinopathy. Calcium dobicelate orally used. Okay, so coming to the recent techniques that are used apart from laser. Laser, you know how to do it. So now intravitreal injections, anti-VEGF injections to combat the effects of vascular endothelial growth factor, you have pegotamib sodium, ranibizumab, and bevacizumab, and eplibart. These are the medications that can be used intravitreally so as to combat the advanced diabetic retinopathy changes. This is just a diagrammatic representation of how the parafoveal grid laser photocoagulation is done. You must be very careful not to photocoagulate the disc. You must be careful not to photocoagulate the macula. You must be very careful about the vessels which are present. You should not photocoagulate. These are the precautions that you have to take. You should not photocoagulate the vessels also, and your assistant should invariably wear a protective goggle while laser photocoagulation is being done. These yellow spots are nothing but laser spots which are applied to the parafoveal area in a case of macular edema. This is a diagrammatic representation of pan-retinal green laser photocoagulation. Diagrammatic representation of these yellow spots which are seen in the periphery. You can see that they are applied both in the mid-periphery and far periphery. This is a picture of pan-retinal green laser photocoagulation. There are three pigments in the retina: melanin and xanthophyll, hemosiderin. These pigments absorb the light energy and convert this light energy into heat energy. Once it is converted into heat energy, these yellow spots are formed on the retina. Treatment of advanced diabetic eye disease. So the advanced eye diseases can be treated by posterior vitrectomy. I think I have already told you how the posterior vitrectomy is done. This is again a diagrammatic picture of three-port vitrectomy, which we have been doing nowadays. For irrigation, you have a cannula, you have an opening. For endo-illumination of the vitreous cavity, you have one more route through the pars plana. Then vitrectomy cutter, it not only cuts the abnormal vitreous, but it also aspirates the abnormal vitreous. Again, it's a new technology, three-port vitrectomy. You must remember that for doing three-port vitrectomy, you have to have a very good quality operating microscope. You have to have a contact lens. If you don't want to use a contact lens and touch the cornea, I told you in my previous class that you have to use an equipment by name biome, which can be attached to the operating microscope. It will not touch the cornea, but still you have a crystal clear view of the posterior segment. Biome is nothing but binocular indirect ophthalmo microscope, which is attached to the operating microscope, and you can beautifully visualize various structures in the fundus by using this particular equipment. I think with this, I will conclude. It's a very important chapter, diabetic retinopathy. Many times it can come as a main question, and various aspects of diabetic retinopathy can be asked as short notes and viva voce questions. So I request you to kindly go through all the aspects of diabetic retinopathy and remember almost all the aspects of diabetic retinopathy. Thank you. ಅದೇ ಅಟೆಂಡೆನ್ಸ್ ಎಲ್ಲ ತಗೊಳ್ಬೇಕಲ್ಲ, ಅದೆಲ್ಲ ಗೊತ್ತಾಗಲ್ಲ. ಎಂಡ್ ಮೀಟಿಂಗ್ ಅದೆಲ್ಲ ಗೊತ್ತಾಗಲ್ಲ.